Welcome to Around the Rheum, brought to you by the Canadian Rheumatology Association. This episode has been made possible in part by Boehringer Ingelheim. Thank you, Boehringer Ingelheim, for your generous support in sponsoring this episode. The scientific integrity and objectivity of all podcast content is overseen by an independent CRA committee to ensure the highest standards.
We have to accept that in certain problems, both diagnostically and therapeutically, we may have to just dwell in that uncomfortable uncertainty, and we just have to come up with a plan, right? I often say to myself, I have a difficult case. I plan out A, B, and C first, so that when A doesn't work, I'm not stuck there wallowing in despair. I say, okay, let's move on to B. I think it's good to be comfortable with uncertainty when we're dealing with rare diseases.
That's Dr. Chen. He is a hematologist and professor of medicine at Dalhousie University here in Halifax. His clinical and research interests are in rare inflammatory diseases. He spent most of his career in Vancouver, where he was also an honorary rheumatologist, before moving to Nova Scotia in 2023, where he founded the Coastal Rare Inflammatory Diseases Program to support physicians caring for patients with rare diseases from BC to Newfoundland. He joins us for a discussion on hypereosinophilia on this episode of Around the Rheum. We're recording this in person at the CRA's 2026 Annual Scientific Meeting in Halifax. Welcome, I'm Daniel Ennis, and a warm welcome to my fabulous co-host, Dr. Janet Pope. How are you?
I'm great. How are you, Daniel?
I'm a little tired, but it's really nice to see you.
Yeah, that time change gets to you, but it's great to be
It's
here.
a little rough. Let's get to our guest then. So, Dr. Chen, welcome to Around the Rheum.
Oh, thanks. It's such a pleasure to be here, Dan.
The pleasure is all mine. It's really nice to finally get you on the show. We've been hoping to do some episodes with you for a while, and I'm excited to have this face-to-face because when you were in Vancouver, and even still now that you're in Halifax, we share some eosinophilia cases
Yes, we
that
do.
are real head-scratchers, and I'd love to kind of just bask in this a little bit and kind of hear your thought process when we go through these cases. So, maybe just to set the table, a good starting point is I would love a hematologist to tell me what is an eosinophil and what is its general function.
Great, yes. Eosinophils are a type of granulocyte. We have three types of granulocytes: neutrophils, eosinophils, and basophils, and that's their order of natural abundance. And typically in the peripheral blood, your eosinophils are about 0 to 0.7 billion per liter. So about a third as many eosinophils as you have neutrophils. And they typically are thought to mediate allergic reactions and reactions to parasites. So they typically will migrate to tissues, and they're full of these eosinophilic or pink granules. And they're eosinophilic in contrast to the basophils, which are bluish or purplish granule-filled granulocytes. The eosinophils are filled with these granules that have things like eosinophilic cationic protein and major basic protein, as well as natural heparins. When they coordinate a response against parasites, they can work quite well, but when you have a pathologic accumulation of eosinophils in tissues, it can lead to a lot of inflammation and tissue damage.
And this is still table setting. We'll get into more specifics, but you see a lot of eosinophilia, and we know, Jen and I, that there's some eosinophilia in some of our rheumatologic diseases. What big categories or groups of disorders do you see eosinophilia occur in?
That's a great question. One of the reasons I get asked a lot about eosinophilia is that on paper, it looks very easy to work up.
Right.
In practice, it's much more difficult. On paper, the idea is that you look for, if you have persistent severe eosinophilia, you look for a myeloid clone, which is done on bone marrow biopsy and genetic testing, molecular testing. And if you don't find one, then you look for reactive or secondary causes. And then if you've ruled out all the reactive or secondary causes, then you call it Idiopathic Hypereosinophilic Syndrome or Idiopathic Hypereosinophilia. And the trick is that second part. Because the first part is relatively easy. If it's severe enough that a hematologist does a bone marrow biopsy and you send off all the molecular testing and genetic testing, if there's a myeloid clone, that should pick it up. But the tricky part is that second basket of secondary or reactive causes, because there's a wide variety of different conditions ranging from the notoriously difficult to diagnose EGPA or Sjögren-Strauss syndrome to the exotic parasitic infections to somewhat newer entities like IgG4-related disease, genetic disorders like STAT3 mutations and Job syndrome, and single organ overlap syndromes like eosinophilic gastroenteritis, eosinophilic asthma. They're often conditions that no one single specialist is comfortable evaluating and ruling out by herself or by himself. So that's the tricky part.
And a question along that, how often would meds be the cause?
It's a great question. It's relatively rare these days, I think. Some of the traditional medications like L2, we just don't really use that much in clinical practice.
It's interesting that you phrased your workup as investigate for a myeloid clone and then look for other secondary causes if you don't find one. Janet, I'm curious, in your clinical practice, when you're involved in an eosinophilia case, is that the order of operations? Does it start with bone marrow biopsy first, other investigations second?
So if it's an inpatient, we look for weird and wonderful infections, as you say, the helminths and stuff like that. But we're often wondering, especially if they have a rash or something, if they don't have asthma, I think we're wondering, is this EGPA? But they would, by the way, usually have asthma if they're sick enough to be in hospital with it. And meds sometimes, because some of our drugs, we can watch the eosinophil count slowly creep up, even drugs like leflunomide, like common drugs that we use, but they're usually never sick with it. They usually doesn't do a heck of a lot. So I think we think, oh, is this sort of an allergy thing? Allergy to drugs, an allergic thing that where the allergist will know, or is this a rheum thing? And then I think we say, oh, it's heme. But if they have really high eosinophil counts, we blame heme first.
Yeah. So that sort of brings us to like the approach to the investigations.
Yes.
And you wrote a really, I still quote it to my trainees. You wrote a really nice paper with Julia Tan and Dan Mahler and Molly Carruthers and Natasha Dagon, and I hope I didn't forget those
main players.
Okay. It was a really nice paper because it's outlined like from the beginning, you have eosinophilia that's persistent. What do you do?
Yeah.
And I think it was really helpful for me because it let me see the hematology side of all the rheumatology, other infectious diseases side. Can you give the broad outline of that for listeners just so that they hear? Patient is sent to you with eosinophilia. What do you do? What is your investigative pathway or approach?
Great. Yeah. So I think the two main buckets are how sick is the patient and how severe is the eosinophilia and how persistent is it? Because you can get transient eosinophilia from a drug exposure like DRESS, or they call it DHI these days. But if it's persistent and severe and the patient is sick, then of course that warrants a much more expedited course of investigation. We get a lot of mild eosinophilia. In Nova Scotia, when I moved here, I noticed that the reference range was less than 0.5 billion per liter, whereas when I was a resident in BC, the reference range was up to 1 billion per liter. So if you move the reference range down, boy, you get a lot more referrals, right? And my rule of thumb of it is if they're not persistently more than 1.5, it's very rare to find something interesting, right? Like once in a blue moon, I get someone who's got an eosinophilia 1.1 from a strongyloides endemic region, and you find they've got strongyloides, and you send them DID and they get treated, and that's nice and satisfying. But most of the time, the people who are wandering the earth with the eosinophil count of 0.8, 1.1, feeling well, you're probably not going to find anything interesting, right? It might be worth doing some parasite testing and just some basic clinical history and exam. Where I start to investigate more is if they're persistently more than 1.5. But even then, I find the ones who are persistently 1.5 to 3, I may do some non-invasive testing like peripheral blood flow cytometry and autoantibody testing, but they rarely yield anything interesting as well, unless there's associated clinical symptoms. Right. So if someone has the main target organs for eosinophil-related damage are skin, sinuses, lungs, GI tract, right? So if on clinical history, they don't have any involvement of those target organs and their eosinophils are less than 3, it's much less likely to be something interesting. Now, where you'll almost always find something interesting is someone with a persistent eosinophilia more than 3 and classic end organ damage, eosinophilia throughout their GI tract and chronic diarrhea or malabsorption, or lots of skin lesions, pruritus. So those are the patients who tend to be more interesting and warrant the more thorough workup. And I should also say that although I say, rule out myeloid first, that's usually reserved for the more severe cases, right? I think for the typical patient with eosinophil count of 2, it's really a good history and physical exam that comes first, that then helps to direct the rest of the investigation.
Atopic, asthmatic, young adult, that kind of thing.
Exactly,
Yes,
exactly.
Bone marrow biopsy then is reserved for either they're coming in sick, they have a really high eosinophil count, there's no other specific cause obvious from their history. They probably do need a bone marrow biopsy kind of concurrent with your other investigations. If they're more stable, modest eosinophilia, that could probably wait for more of a second line investigation.
I think that's true. Yeah, basically, for the vast majority of patients that I see for eosinophilia in my clinic, the bone marrow biopsy won't be on the first visit,
Right.
even to me, right, by the time they get to me. So it's, of course, if someone comes in with an eosinophil count of 10 and they're unwell, then I'll do the bone marrow biopsy that first visit. But a lot of patients, eosinophil count of 2, 2.5, symptoms are relatively mild. Let's do a good history and physical exam and a good first pass, non-invasive set of investigations first.
Can you dig down a little bit more into which are the hematologic disorders that cause eosinophilia? So myeloid, like eosinophils are myeloid. Is it exclusively myeloid disorders you're looking for, or is there some spillover when you get other cell lines involved with the malignancy?
That's a phenomenal question. Maybe I could just preface this by just saying, like, when someone is referred to me for eosinophilia, the typical tests that I do, and I usually get them to do these tests before they come to me, because then I have a good sense of how to approach them, because there's just so many things that cause eosinophilia. So I usually will do a CBC and differential and serum protein electrophoresis, liver enzymes. I will typically do IgG subclasses or IgG4 and an IgE level. C-reactive protein is really useful. I know some of my ID colleagues really don't like C-reactive protein, but C-reactive protein is super useful in these cases. And then I'll typically do an ANCA, C3, C4, sometimes some other antibody testing. In Vancouver, I routinely did strongyloides serology and stool for OMP. Here in Halifax, I've stopped doing that routinely just because I've picked up some false equivocals or false positives from people who have never had an endemic exposure. So I think that depends a little on your pretest probability. But out of all the things that can cause eosinophilia, the one you don't want to miss is strongyloides, because that's all the other things that cause eosinophilia. If you give them steroids, they'll probably get better, but that one may get worse. So I don't want to miss that. So that's my typical approach to the first pass non-invasive. And then for most people, I will do flow cytometry for lymphocyte variant hypereosinophilic syndrome and peripheral blood T cell clonality. And I'll come back to that because the lymphocyte variant hypereosinophilic syndrome, from what I've seen, probably the only two places in Canada that do it properly are Vancouver and Halifax. So we'll get back to that.
For some link, there's a linked
Yes.
reason. So before we get there, how does the CRP help you high versus normal? Because we love CRP as rheumatologists. We think it's the best thing ever sometimes. So what would a low help you, point you versus a normal versus a high, a normal versus a high?
Yeah, great question. I say persistently high, like more than 30 milligrams per liter or so, makes me really suspicious of an eosinophilic vasculitis or EGPA. And that one is really hard to separate from idiopathic hypereosinophilic syndrome because, as any rheumatologist knows, a lot of people with EGPA or eosinophilic vasculitis will have a prolonged eosinophilic prodrome before they develop biopsy-proven vasculitis. And so how do you know that it's the eosinophilic prodrome of EGPA versus idiopathic hypereosinophilic syndrome? I'll give you an example. The mecca of eosinophilia research is Amy Cleon and Dr. Panise Corey's group at the NIH in Bethesda, Maryland. And they sometimes publish papers where there's this lump of query eosinophilic vasculitis / I-HES, meaning even they can't tell which one it is, right? And if they can't tell, how can the rest of us, right?
That actually came up at a recent meeting that reviewing some of that data, someone in the crowd asked a question, wasn't that just EGPA?
Yeah.
And she was upfront that these can be hard to differentiate.
Yeah.
And so let's talk about that then.
Yeah.
idiopathic HES
Yes.
and EGPA. I think I have two super experts here, so this is actually really helpful. You've mentioned some of the distinguishing features, but can we go through that in a little bit more detail? How is a rheumatologist to decide if someone has EGPA, or when should they be suspicious that maybe the label is actually a hematology disorder, it's idiopathic HES?
Yeah, it's a great question. Maybe I could get Janet's take on it first, and then I'll dive in.
Sure. So we're going to look, in general, there's a referral bias.
Yeah.
So we are going to look for mononeuritis multiplex, late onset asthma and severe. Is there anything cutaneous? What's the ANCA? So is it P or C or none? Is it borderline? P-ANCA is sometimes very non-specific for us, right? So what are the ANCAs doing? We do see people obviously with lung lesions, NSIP, or actually cavitating lesions sometimes, and cardiac. So if somebody has heart failure at a younger age than we would expect, or HFF or something, I'd be saying, wow, this really could be a systemic vasculitis. Whereas I don't even know when I last saw someone with eosinophils more than 3%, like maybe once 10 years ago kind of thing, because I just don't think those other folks come our way. So if we say eosinophils are high, asthma is just borderline, it's been all their life, there's no skin lesions, there's no other systemic things, their sinuses seem to be okay, even if I haven't looked too hard yet on CTs and stuff, because we would tend to look for it if we think it is an EGPA. So we'd start scanning. And if it's IgG4, for us, there's usually a lump somewhere, because I don't know if the GI, like the bile sclerosing kind of people with the bile ducts, we don't tend to see them, because the pancreatitis and the bile jobby people, they seem to go right to GI. They don't seem to need a biopsy. They look at imaging and it's pathognomonic. So I'm not sure how high their eosinophils go. So our IgG4, we're usually seeing lymphadenopathy, cutaneous, stuffed bulgy lacrimal glands or something. We're seeing people with things that look like they could be rheumatologic. So that's how I would do it. And then if we can't find anything, I think we'd say, I don't know, you're on steroids now, you're getting better, but why don't we punch you over to heme and see if they can do better than us? So that's what I would do. So let's put it at your perspective, because there are different referral biases, of course.
Let's punt to heme. What do you think?
I think the EGPAs are really tricky. I think if they have obvious sinus and asthma involvement, or mononeuritis multiplex is a giveaway. There's not too many other things that cause eosinophilia and mononeuritis multiplex, so that's almost certainly EGPA. But the persistently high CRP is very helpful. And then there's a lot of overlap between eosinophilic syndromes, IgG4-related disease, and EGPA. But then it's helpful to know what are the distinguishing features. So IgG4-related disease, unless there's active aortitis or a concomitant infection, very unusual for IgG4-related disease to have a persistently elevated CRP more than 30, right? Very unusual. The part of the ACR-EULAR classification criteria for IgG4-related disease, they say eosinophils more than 3 make it less likely. So if people with IgG4-related disease do have more profound eosinophilia, it's also usually very wimpy. Like one dose of prednisone, the eos go from 5 down to 0. So it's not resistant. It just melts away with steroids. So I think just having an awareness of all those tests and how to interpret those tests is very useful, right? We all know that a lot of the CRPs are going to come back abnormal, but how high is worrisome for EGPA? In my mind, like persistently more than 30 is when I start thinking about the vasculitides. And, a serum IgG4 level, if it's, lots of people have serum IgG4 level of 2 to 3 grams per liter, but if it's persistently more than 5 or 6, IgG4 related disease, EGPA are two of the few things that actually do that and make it that elevated.
I think like what I've seen clinically is it becomes really hard, like in the vasculitis clinic. I think maybe this is giving up too easy, but when we don't see vasculitis, there's no organ that clearly has vasculitis. So you mentioned the mononeuritis multiplex.
And renal, we're going to always look at urinary sediment, yes.
They have LCV, right, leukocytoclastic vasculitis on their skin, or they have scleritis, or some of these things that you're like, okay, that is vasculitic. That's very unlikely to just be idiopathic HES that's so bad that the eosinophils are infiltrating nerves or wherever. While not inconceivable, it's a bit easier to say, all right, we have vasculitis, so it's a vasculitis. We're done. And then it's just our job to decide which vasculitis. And if they have a bunch of eosinophils, you're probably going to be leaning towards EGPA. But south of that, when they are in the in-between stage, which, as you pointed out, that can be a really long time between onset of, asthma and sinonasal symptoms to diagnosis, mean of 8-9 years between those things, from there to the vasculitis or systemic phase. That's the area where I have the most trouble, because if you have bad hypereosinophilic syndrome of any cause, you get eosinophils spreading all over.
Yes.
And so south of the vasculitis, the syndromes can look remarkably similar. So then what are the super specific non-vasculitic manifestations? I always thought that asthma was going to be, if they have asthma, it's 100%. But I'm finding that, one, Dr. Corey and some of her work has indicated rates of asthma that are a little bit higher than I would have hoped, something in the order of 15 to 20, 25%, which bothered me, not because I think she's wrong or anything, but that was supposed to help me differentiate these disorders. Like how many?
Sorry, asthma in what? 15,
Asthma
20% in which condition?
Idiopathic.
Oh, yes. Yeah.
And so that was tricky to hear, because I really thought that was going to help me distinguish that asthma is, and we're talking about new onset, difficult to treat, advancing asthma as part of the syndrome, shouldn't be part of idiopathic HES. I guess this is where I want to hear your experience. I think maybe the sort of answer is in between, where it should push you towards EGPA if they have those asthma symptoms. But in your expertise, do any of your patients have new onset, aggressive, difficult to treat asthma and their idiopathic HES?
I think that phenotype does exist. I think there is something called eosinophilic asthma. And what I would say is I fixate on diagnostic labels so that I can get my patient to the right treatment. Because there are a lot of effective treatments out there for eosinophilic diseases, right? JAK inhibitors are miraculous for some of these patients, especially the ones with dermatologic disease and pruritus, right? We never really had good treatments for diseases that cause severe pruritus until the JAK inhibitors came along. Dupixent can be really good for gastrointestinal disease. Eosinophilic asthma, they should be on an IL-5 inhibitor, right? And so my main purpose in getting the most precise diagnostic label possible is so that patients can access the treatments that they need, right? We're not trying to get a diagnosis so that we can sit there in our academic chairs and go, how clever I am. I got the right diagnosis, right?
I'm doing that, yeah. I'm doing a little bit.
Yeah,
you're absolutely right. Yeah. Patient first.
Yes.
You're really right to point that out, that the goal here is, are we not splitting hairs a little bit if this is an unsolvable, very subtle mystery?
I think,
there.
It's a journey, right? And we have to remember that our final destination is the right treatment, right? Of course, we want everything else, the right diagnosis, be able to tell the patient the natural history and prognosis and those sorts of things. But I've seen thousands of my patients over my career, and I've never had a single patient say to me, I just care the most about you getting the most precise diagnosis, and I don't care if you get me to the right treatment. No, it's the other way around, right? Every single patient says, you know what? I don't mind if you're a little bit uncertain about the label, as long as you put me on the treatment that, it gets me feeling better and living longer, right? Yeah. So that's the goal. So that's what we have to keep in mind. So having said that, along the way, anyone who's sick enough to have seen one of you and me probably needs a bone marrow biopsy, right? And the value of the bone marrow biopsy is that once you've done it, it's very easy to send the cytogenetics, the FISH, the molecular, to look for the specific lesions. So the actionable lesions are PDGFR-A. There's an interesting story behind that. Like when imatinib, the tyrosine kinase inhibitor, first came out in the late 90s, early 2000s, at the Mayo Clinic, they decided to test it on some of their patients with HES, and they found, wow, some of them respond really well. Our standard dose for chronic myelogenous leukemia is 400 milligrams a day, but some of these HES patients would respond to 100 milligrams a day. And so they went hunting for a cryptic tyrosine kinase mutation. They found this tiny little PDGFR-A mutation, and then they went looking for other ones, and they found this PDGFR-B mutation, which you will see on a regular karyotype. The PDGFR-A you won't see on a karyotype. You have to either do FISH or PCR for it. PDGFR-B, it's big enough that you will see it on a regular karyotype. And those two respond very well to tyrosine kinase inhibitors, to imatinib. So of course, that's why it's important to hunt for those ones. Then FGFR1 came along. I've not I've personally only been involved in one case. That one's a really bad actor. Usually the patients are really sick. They develop a bad lymphoma, leukemia. They probably need a BMT doctor to see them rather than just a regular hematologist. Our most standard FISH panels include those three. And then the fourth one, the newest one, is JAK2 PCM1. So not the JAK2 617F that we test for in polycythemia vera, but a rearrangement of JAK2 with PCM1. And that one, I've not personally come across the case yet, but it's also part of our standard FISH and molecular panel, and it wants JAK inhibition. So those ones, that's basically why we do the bone marrow biopsy, is to do the molecular testing for those things. Or sometimes you find that there's increased number of blasts or a lot of dysplasia, and so they clearly have a myeloid clonal disorder, and so they need to get treatments like hydroxyurea or, in very severe cases, bone marrow transplant. Those are exceedingly rare. The vast majority of eosinophilic disorders will either end up as a secondary cause or maybe idiopathic hypereosinophilic syndrome. So we've mentioned some of the very important secondary causes to rule out. If someone comes from an area that's endemic for parasites, or they hunt wild game and that sort of thing, I'll usually send them to an ID specialist, just make sure we're not missing anything, right? And obviously, if they had whatever target or organ is involved, I'll ask a respirologist or a gastroenterologist or an allergist to see them and go over those things. You had this young lady referred to me for eosinophilia and these skin lesions, and I asked her, was this long serpiginous lesion on her arm? I was like, what did that come from? And she said, oh, my pet rat urinated on me. And every time my pet rat urinates on me, I get these, and I'm like, oh, yeah. I think I know what the problem is. And sure enough, it's the rats.
We've all been there.
Yes, exactly.
It's a dirty rat.
Yeah, exactly.
Dirty rat.
So involve the appropriate specialists and perhaps get biopsies of the affected tissue. But and then now we know about IgG4-related disease, and I don't need to teach rheumatologists about IgG4-related disease, but that's an important cause of usually mild, usually transient eosinophilia. And then the one that I find gets missed a lot is this thing called lymphocyte variant hypereosinophilic syndrome, or LHES. And this one's really important to know about because unless you look for it, you'll never find it. So classically, they usually have skin lesions. And it can be all sorts of different types of skin lesions, from just diffuse atopic eczema to more discrete acules and papules. It was discovered in 1999. A French dermatology clinic decided to look at their patients with skin rash and eosinophilia, and they found that a lot of them have an aberrant T cell population. The classic T cell population is CD4 positive, CD3 negative, because if a T cell expresses CD4, it should express CD3. So they've realized that was aberrant, and most of them are clonal by PCR, and they often have some small lymph nodes as well. And it can be mistaken for lymphoma. But it's really important to make the diagnosis because, one, the patients are often very uncomfortable, especially from their skin lesions or sometimes from GI symptoms or lung symptoms. And two, the treatments are very effective. Either they will respond to interferon alpha, and sometimes people say, oh, interferon alpha, that's barbaric, but that's the old interferon alpha. If you give them pegylated interferon alpha starting at a low dose, 90 micrograms sub-Q weekly, and titrate up to a maximum of 180 a week, it almost always works, and it's usually very well tolerated. So I've had people come to me with this mysterious skin rash that they've had for 8 or 9 years, eosinophils of 10 or 12, and they'd seen specialists, and they say, oh, I don't know what you have, and I do the flow cytometry, which is the test, and the hematopathologist calls me and says, oh, they have a huge population of CD4 positive, CD3 negative cells, right? You put them on interferon, and within a few weeks, their skin's like a baby's again. So that one's really important to know about. And the thing is, you have to, if you're in a center where you're not sure if they do the flow properly, talk to your hematopathologist, whoever does the flow. Ask them, are you able to identify these cells, these CD4 positive, 3 negative cells? And there's a couple of other variants. There's CD4 positive with loss of 7. That one's a little less specific. So I had someone with pretty good going loss of 7, but my rheumatology colleague just called me a month ago and said they now meet criteria for EGPA. So that's probably a better diagnostic label. And there's also the CD3 positive, 4 negative, 8 negative, the double negatives. If you find those, then I would also send the flow panel for ALPS, because most adult centers, they don't distinguish between gamma delta and alpha beta, whereas the ALPS, the more specific phenotype is double negatives that are mostly alpha beta. And so you want to do flow cytometry for lymphocyte variant hypereosinophilic syndrome and T cell PCR for T cell clonality, and talk to your pathologist to see if they know how to look for those things.
We'll talk to the hematologist and say, please tell him that path, right?
Yeah.
A question, in your experience, do you think some organs just aren't very treatable? Don't know, as a for instance, because I don't see them getting treated if we diagnose them somehow. They go off for scope. Is eosinophilic esophageal conditions, is it treatable? Or do they just eventually fade a bit?
That's a great question. Some of the single system overlap syndromes, I will admit I don't have as much experience with because they often stay with that specialist. So the gastroenterologists have a lot more experience with EOE than I do. And EOE rarely manifests with systemic manifestations. It tends to be single organ. It's probably related to IgG4 specific food interactions. I do know that there's data, traditionally they use these budesonide slurries, but Dupixent also seems to work. Yeah, that one I would defer more to the gastroenterologists.
Just as we move towards the end of our chat here, you mentioned a lot of the treatments for some of the kind of specific entities within the hypereosinophilic spectrum. When you have someone who is truly just pure idiopathic HES, can you give us a bit of an approach to which treatments you usually begin with and then advance to?
That's a great question. Steroids are usually the mainstay of treatment, but there's a couple of different bucket treatments that I think are useful for eosinophilic syndrome. So in the lymphocyte variant hypereosinophilic syndrome, it's interesting because it's a clonal process, but the eosinophils themselves are not clonal. They're reactive to the IL-4, IL-13, IL-5 that are being produced by the clonal T cells. And so for whatever reason, the interferon alpha really shuts down those T cells. Really, you'll see the IL-5 level go down if you're able to measure that. And more importantly, eosinophils go down and the skin and the other target organs clear up. And I'll just mention also that one is sometimes mistaken for T-cell lymphoma, which can be disastrous. So the very first case we diagnosed in Halifax was referred for consideration of transplant because they thought that she had chemo-refractory T-cell lymphoma. And she was the first person that we flowed in Halifax, and we found she had the classic phenotype. And so she actually went on to ruxolitinib and did really well, because the other thing about those is the T-cell disorders are very responsive to JAK inhibition. And I know the rheumatologists often have samples of JAK inhibitors in their clinic. So I'll sometimes go to steal some samples from one of my rheumatology or dermatology colleagues.
We probably have some on us. Right?
Yeah, I probably have selling it.
Yeah, exactly. I think I've lost track of the original question, but
when you have ruled out all of these interesting rare disorders and you're left with true just idiopathic, you had said corticosteroids work really well. And we also see that in EGPA, where usually the eosinophils disappear quite quickly. Mild to moderate disease, you can make a reasonable case for just corticosteroids as your first round agent. I'm curious, from a hematology side, what's your stepwise strategy?
Yeah. If there's more of a myeloid flavor to it, that I like hydroxyurea, I will say I rarely use it. If they have GI and skin involvement and I can't access a biologic, I do mycophenolate mofetil. I find MMF can be quite effective. But otherwise, I try and lump them to the closest thing that we can access drugs for. I'll say that in idiopathic hypereosinophilic syndrome, to my knowledge now, there are 2 randomized control trials. There's Florence Rufos did the FLAIR study published in Journal of Allergy and Clinical Immunology in 2020, showing that mepolizumab is very effective at controlling symptoms and reducing corticosteroid exposure in idiopathic hypereosinophilic syndrome. No surprise. And then just the past month, Amy Cleon's group published in Nature Medicine a study looking at benralizumab. And it's also very effective at reducing symptoms, reducing steroid exposure. So for those patients where, a course of steroids wasn't enough, as soon as you taper them off, their symptoms flare up again. We do have data that the IL-5 inhibitors work, but how do you get them? Right?
You make their asthma bad enough.
Exactly. So I really lean a lot on my respirology colleagues, because it seems like as soon as a respirologist says they have bad eosinophilic asthma, they can access those things, right?
Yeah.
And then likewise, if they've got GI involvement, then I often ask my gastroenterology colleagues, what do you think? Can we get them dupilumab? Because often the coverage is restricted to those disciplines. And then if there's a lot of skin involvement, if there's a lot of pruritus, then I really like JAK inhibitors. And it's whatever JAK inhibitor you can get a hold of, right? I'm a hematologist, so I'm sometimes able to get ruxolitinib through a compassionate access program. That one causes a lot of weight gain. So if my dermatology colleague can get upadacitinib, or my rheumatology colleague can get tofacitinib, then why don't we try those ones?
Makes a lot of sense.
I will also just mention, like, I was listening to the difficult to treat rheumatoid arthritis talk earlier, and it was just amazing to me how quickly, bang, you move through treatments, right? You try something, it doesn't work, bang, move on, right? I find there's often a real reluctance to do that in rare diseases, and I don't really understand why, right? Basically, there's a couple of things that are going to work: steroids, MMF, pegylated interferon, a JAK inhibitor, an IL-5 blocker, and IL-4 blocker. You try one, it doesn't work, move on to the next one, right? Don't just sit there wallowing in despair.
Yeah.
I think it's our lack of certainty of the actual diagnosis sometimes.
Yes.
Because I think we're comfortable with EGPA. When we get beyond it, it's multidisciplinary then.
Yes.
It's easy enough, though, if they have asthma to have rest, tell us what to do. They might even bronch them to make sure they're not missing something else. They sometimes skin test them, etc. So they help us out. But most of those folks, the eosinophilia is 1%, things like that. It's
Yes.
not 3%.
Yes.
I think you're right to put a plug in for a more bold approach with some of these diseases, because we were just chatting about a complicated patient we shared before, and the lag between the last treatment she's tried, which hasn't worked, and the next treatment we're suggesting that we're hoping to initiate for various reasons. It's not going to work, but just the lag in between there is probably a real misery for
Yes.
her. And you're right, we have to think about that. If it was me, how long would I let someone lead me on interferon or MMF before I was
Yes.
like, all right, well,
Yes.
what's next? This mechanism doesn't
Yes.
seem to be quite right.
Yes. I'll tell you, like, 2 quick stories. So that lady that I talked about who was referred for allotransplant, right? When she went on ruxolitinib, all her ulcers on her skin cleared up, her eosinophils, lymphocytes, everything went to normal, right? So she didn't need a bone marrow transplant. She just needed ruxolitinib. And then I saw another lady from Prince Edward Island who'd been suffering from this bizarre respiratory dermatologic syndrome with eosinophilia. I did the $1 million workup. I checked everything on her. I couldn't find a myeloid clone. She didn't have lymphocyte variant hypereosinophilic syndrome. IgG4 levels are normal. But because her main problem was her skin, she was sloughing off so much skin that every day she had to wash her bed sheets. I just asked her dermatologist, do you have any upadacitinib samples? Can you just give her a bottle of upadacitinib, give it a try? And she said within an hour of the first dose of upadacitinib, her skin felt better. Within 3 days, it was back to normal, right? She'd been
Wow.
suffering with this for 3 years. And all we had to do was just take a sample off the shelf and let her try it, right?
And it comes to rare disease, off-label. It's everything we do in a rare disease is often off-label. But if we can be thinking about it, then at least we can pick the right kind of off-label drug to help them.
Yeah.
You really did outline, you try and use something of a phenotypic approach. If it's idiopathic, then your treatment, you draw from what does it look most like?
Yes.
And I think we do that actually quite often in rheumatology. I think that's part of the skill set is we don't always have a definite firm diagnosis, but we have enough peripheral knowledge to say this phenotypically is similar to pan or...
And then we use the drugs we use. So
Yes.
if their asthma's not too bad and we think it's EGPA, they're going to get Rituxed.
Yeah.
If their asthma's bad, they're going to go down the asthma biologics that you mentioned. So
Yes.
we also say, okay, I can get access to this.
Yes,
What can you
for
get
sure.
access to?
Yes.
And then you move it together. I think some of the fear, which this podcast will hopefully help the colleagues with, or at least myself, is I'm always thinking I'm missing a hematologic thing that I'll partially treat with a whole bunch of prednisone.
Yes.
Then they can't make the diagnosis, and then it might be worse outcomes later. And I think the reassuring thing that you're telling us is the people we see do not have 3 to 10% eosinophils that are persistent. And I think that's really helpful because as soon as it looks way out of what we're used to, we will get another specialist involved. We'll get
Yes.
heme involved, ID if we think they've had a travel history or
Yes.
diarrhea, or they think they had worms or something, their kid had
Yes.
worms, whatever. That we'll start looking harder at other things. So I think that's really helpful. It's a great approach.
Yeah, thank you. I started out my career in medical education, and there's this idea in education called a threshold concept. It's a threshold concept is a portal of entry into expertise, right? Like in math, if you study math or computer science, you really have to be comfortable manipulating complex numbers, so numbers that involve the square root of -1 to really get good, right? And a lot of people get stuck at that threshold. Or if you go into engineering, you have to really understand critical flow. And so I looked at what are some threshold concepts in medicine. One that kept coming up was uncertainty. And at first I was like, oh, that's a cop out. Uncertainty, that's a dumb one. That's not as good as critical flow or complex numbers, right? But if you think about it, that is crucial to what we do in medicine. We have to accept that in certain problems, both diagnostically and therapeutically, we may have to just dwell in that uncomfortable uncertainty. And we just have to come up with a plan, right? These are the diagnoses that I'm not going to miss. And once I've ruled out those things, I'm going to try this patient on these treatments. I'm going to try A, B, and C. I often say to myself, when I have a difficult case, I plan out A, B, and C first so that when A doesn't work, I'm not stuck there wallowing in despair. I say, okay, let's move on to B, right? So I think it's good to be comfortable with uncertainty when we're dealing with rare diseases.
And always still reassessing. We get the diagnostic blinders on, and that's why it's even like to characterize. Sometimes we'll say things such as possible EGPA because of A, B, and C, we say, however, not fully confirmed. That kind of stuff, I think, keeps us open-minded, and it's helpful.
Yes.
But in the end, you got a patient in front of you who's suffering where some of our treatments could help.
Yes.
We want to do no harm, but we certainly want to help as well.
Exactly.
So it's very helpful.
Dr. Chen is a hematologist and professor of medicine at Dalhousie University here in Halifax. I wanted to thank you very much for coming on the podcast and sharing your wisdom with us.
Really a pleasure. Thanks so much.
That's it for this episode of Around the Rheum, recorded here in Halifax at the CRA Annual Scientific Meeting. Around the Rheum is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We would like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. Our theme music was composed by Aaron Fonwell. If you enjoyed your time with us, please give us a rating and review where you listen. It helps us to build our community. And please subscribe so you don't miss future episodes. With Janet Pope, I'm Daniel Ennis. Thanks so much for listening.